Welcome to This Explainer. Today, we're zooming in on a highly specific and honestly kind of fascinating complication that can pop up after cataract surgery. We're talking about a condition that actually threatens a patient's vision after what might have been a completely flawless textbook operation. So let's dive right in and demystify capsular phimosis. So what exactly are we dealing with here? Capsular phimosis, which you might also hear called anterior capsular contracture syndrome, is essentially the purse string shrinkage of the capsular rhexis edge following cataract surgery. Think about that for a second. You have a previously successful surgery, but over time, the body's own healing environment goes rogue and starts actively working against the surgeon's design. To really picture what's happening inside the eye, I love this analogy. The opening gets smaller and tighter around the intraocular lens, or IOL, almost like a belt pulling in. It's this relentless mechanical squeezing right around that carefully placed artificial lens. Here is our game plan for today. We're going to cover who is at risk, the actual shrinking mechanism, the signs and complications, strategies for prevention, and finally, how we manage the condition. We'll trace the whole patient journey. All right, part one, who is at risk? Let's look at patient and surgical etiology. Right off the bat, certain eyes are just predisposed to this rebel healing response. We're looking at young patients because, well, their robust healing response actually works against them here. We also have to watch out for conditions that weaken ocular structures or ramp up inflammation. Things like pseudoexfoliation, uveitis, retinitis pigmentosa, high myopia, and diabetes. If you see these in a patient's history, those are massive red flags setting the stage for contracture. But wait, it's not entirely up to biology. Surgical technique plays a huge role too. You've got to weigh what the patient brings to the table against what happens in the operating room. Things like a small or ragged capsular rhexis, incomplete cortical cleanup, using hydrophilic IOLs, or dealing with highly inflamed post-op eyes. These surgical variables can trigger that tightening belt effect just as easily as underlying systemic diseases.
Moving right along to part two, the shrinking mechanism, pathogenesis and action.
So how does this invisible shrinkage actually happen? It really all comes down to these silent little antagonists, leftover lens epithelial cells, or LECs. You see, even with fantastic cortical cleanup, microscopic cells can still hang out at the capsular rhexis margin. Over time, these residual cells undergo fibrosis. They essentially turn into scar tissue that actively works to pull the anterior capsule inward. Let's break down the exact biological sequence here. Step 1, those residual LECs proliferate and fibrose. Step 2, thanks to that fibrosis, the anterior capsule begins to contract centripetally, meaning it pulls directly toward the center. Step 3, if that initial capsular rhexis was on the smaller side, this relentless pulling tugs the IOL forward and inward. And finally, step 4, this pulling physically alters the lens position, giving you a tilted or decentered lens or a major myopic shift. The cellular biology literally reshapes the physical architecture of the eye. It's wild. Okay, part 3, signs and complications. Let's talk about the clinical reality. Timing is everything here. You have a highly critical clinical window to watch. Day 0 is the surgery, of course, but you need to be highly vigilant starting at just 2 weeks post-op. That's when you see the earliest onset of symptoms. The highest danger window typically closes around 6 months out. But keep in mind, patients with pseudoexfoliation can experience this much later, so they require long-term monitoring. Clinically, this is what it looks like. A patient is thrilled with their post-op vision, and then suddenly, they experience a terrifying drop in their sight. They'll complain of blurring, glare, halos, maybe even monocular diplopia, which is double vision in one eye, along with that myopic shift we mentioned. When you examine them, you'll see a very distinct white fibrotic ring on the capsular rhexis. The IOL might be pushed forward or tilted. In the most severe cases, the visual opening can shrink down to less than 3 millimeters. I want to pause for a second to really emphasize this. Capsular phimosis is not just some weird anatomical quirk. If that belt keeps tightening, you're looking at severe, vision-threatening mechanical failures inside the eye. The stakes of missing or ignoring this diagnosis are incredibly high. The complications range from poor vision due to the IOL tilting or inducing myopia to downright dangerous situations like capsular block syndrome. In vulnerable eyes, especially those with pseudoexfoliation, the tightening can cause zonular dialysis, That means literally tearing the supportive fibers holding the entire lens complex in place. And to make matters worse, once you have a thick, contracted capsule, it becomes incredibly difficult to perform a corrective YAG laser procedure later on. So let's shift gears to part 4, strategies for prevention. How do we stop the shrinkage? The great news is that authoritative, excellent surgical technique can stop these cellular villains before they even start. Surgeons should aim to create a 5 to 5.5 millimeter round, perfectly centered capsular rhexis. They absolutely must meticulously remove the cortex to limit any leftover epithelial cells. Also, using hydrophobic acrylic IOLs with square edges acts as a literal physical barrier to cell migration. Aggressive control of post-op inflammation is crucial too. And finally, for those high-risk patients, like those with pseudoexfoliation or uveitis, physically polishing the anterior capsule adds a vital extra layer of defense against fibrosis.
And finally, part 5, managing the condition and exploring our treatment options.
Sometimes, despite the absolute best prevention tactics, the condition still develops. When that happens, we rely on escalating interventions. Think of this as a quick clinical cheat sheet. If you catch it early in the mild stage, topical steroids and cycloplegics can help reduce the fibrosis. If it bumps up to moderate, doctors can use an NdIJ laser to make radial relaxing cuts, basically snipping that tightening purse string. For severe cases, you're looking at a surgical anterior capsulotomy using a vitrocutter to physically clear the blocked visual access. And what if the force has already caused a tilted IOL? Well, the surgeon may have no choice but to reposition or completely exchange the lens. As we wrap up, I want to leave you with this one provocative question. How does microscopic surgical precision prevent macroscopic vision loss? It's pretty amazing when you think about it. The margin of error is fractions of a millimeter, yet the stakes are quite literally someone's entire visual world. It is a powerful testament to the delicate, high-stakes balance of ophthalmic surgery. Thank you so much for exploring this explainer with me, and keep learning.